Welcome, everyone, and thank you for joining us in today's HSS Myositis Support Group meeting. We are honored and privileged to have with us as our guest speaker, Dr. Rohit Aggarwal. Dr. Aggarwal is a professor of medicine at University of Pittsburgh and medical director of Arthritis and Autoimmunity Center at University of Pittsburgh Medical Center. His very large body of research and areas of interest are clinical and translational research in inflammatory muscle diseases, such as myositis and associated interstitial lung disease. He is the past chair of the Medical Advisory Board of the Myositis Association, as well as past chair of the scientific committees of IMAX, which are the largest patient and physician groups working in the field of myositis. Dr. Aggarwal is an established independent clinical investigator with significant funding from National Institute of Health, foundations, and industry, and is currently leading several collaborations internationally with other key leaders in the world. He has had great success in working with younger rheumatologists to promote interest in myositis research for the advancement of the field. Thank you again, Dr. Aggarwal, for being available for today's presentation.
Thanks for inviting me to present this talk. This talk is more at the level of fellows and the junior doctors or the doctors who take care of myositis patients in terms of the slide. But I'm going to use these slides as a background to kind of talk about the point to explain our patient friends here about various aspects and things about myositis. So here are some disclosures. So what our learning objective of this talk is, we're going to try to understand some subtypes and classification of myositis. We try to understand what the roles of various labs and tests in our diagnosis of myositis. We'll review some treatment and prognosis of myositis. So first of all, what is myositis? Doctors call myositis also with another name called IIM, or idiopathic inflammatory myopathies. In short, people should use the terminology myositis. Myositis, by the way, just means myo means muscle, itis means inflammation, so muscle inflammation. But it's not as simple as just muscle inflammation, as you obviously have dealt with these diseases, so you know it's not just as simple muscle inflammation. So it's a family of systemic autoimmune disease, which means autoimmune disease means your own immune system attacking yourself, and also systemic means it doesn't only involve muscle, even though muscle is a primary target. And it shares these diseases shares chronic inflammation of muscle of unknown cause as a feature, but it often involves several other organ systems. So what are some subtypes or different types of myositis? We traditionally called it like 6 different subtypes of myositis, which were adult patients with polymyositis, adult patients with dermatomyositis, juvenile patients or kids with mostly dermatomyositis. We have something called cancer-associated myositis, and we also have something called connective tissue disease-associated myositis, or some people call it overlap myositis, which basically means that you have another rheumatological disease such as scleroderma or lupus or something else along with myositis. And last but not the least, inclusion body myositis. In last decade, we have recognized some new entities of myositis. 2 of them were previously hidden in polymyositis, but now they're considered their own entities or diagnosis. And those are necrotizing myopathy, or NM, and antisynthetase syndrome, or ASSD. And because of these 2 entities being now considered unique or have their own name, the true polymyositis entity has gone down in numbers significantly. And for dermatomyositis, there is also another unique entity within dermatomyositis called clinically amyopathic dermatomyositis, and we'll talk about that. But because of that, dermatomyositis is now divided into amyopathic or what we will call as classic dermatomyositis. Now, we use the criteria. Every time you have a diagnosis, the doctors in their back of their mind using a criteria to make a diagnosis, or what we will rightly call here is classification. And the classification that has been used previously is called Bowen and Peter classification criteria. It had 5 different bullet points. I won't bore you with the bullet points, but the point is this classification criteria was being used to diagnose patients with polymyositis and dermatomyositis. Now, this classification criteria was developed in 1975. So it worked really nicely for a lot of decades. But now we have recognized that it still works fine for dermatomyositis, but doesn't work well for polymyositis or non-skin manifestations myositis. It doesn't work that well. And the other problem is the reason it doesn't work as well is because dermatomyositis has very few differential, which means the mimickers of dermatomyositis are very few. Typically, I would say lupus and psoriasis are the mimickers of dermatomyositis. But polymyositis, unfortunately, has a lot of mimickers, which means there are many conditions that can look like polymyositis, can even meet the criteria of Bowen and Peter, but they're still not polymyositis. So a lot of time we see misdiagnosis or overdiagnosis of polymyositis, whereas they may have some other muscle problem. To overcome these problems, we developed a new classification criteria, which I will talk to you in a minute. But another problem with this Bowen and Peter classification criteria, it did not have any myositis antibodies. And some of you may already know your myositis antibodies now. And these are very helpful lab tests that can help us to understand what overall disease pattern you may have, or what will be your prognosis, or what treatment might work for you or might not work for you. So because of those 2 shortcomings of Bowen and Peter classification criteria, we developed a new classification criteria, and it took us about 5 to 7 years to develop this. And it is similar to Bowen and Peter, but it has some unique new features. And we are nowadays training doctors on this new classification criteria. But the only point I want to make about new classification criteria is that Jo-1 antibody is part of that criteria. And we also believe that any myositis-specific antibody should be part of the criteria. So we are currently working on revision of the criteria so that not only Jo-1 antibody, but any myositis-specific antibody could be part of the criteria. The way the criteria works is, in this case, is you have clinical features listed, and for each clinical feature that you have, you get a score. And if you're at above a certain threshold of score, then you meet the criteria for myositis. Once you meet the myositis criteria as per this scoring system, then we use this sort of called classification tree system, in which then we decide whether you have dermatomyositis or juvenile dermatomyositis or inclusion body myositis or polymyositis and so on. Okay, so let's go forward. This criteria is quite good. It's been the best criteria we have developed for myositis so far. It's called EULAR ACR criteria. It has a high sensitivity and high specificity. Okay, now coming to who develops myositis. So first of all, as you all know, like any autoimmune disease, females are generally speaking 2 times more likely to develop any autoimmune disease than men. And this is myositis is no different to this. Patients with myositis, there are about 60 to 70% females in myositis as compared to 20 to 30% males. What's interesting is that the frequency of difference, the incidence and prevalence continue to increase as we age. And what's also unique is as we age, the difference between the male and female continues to increase as well, which means older age, more likely that the females would have dermatomyositis and polymyositis, and younger age, males and females could be almost equal. So, which is very unique. We don't know exact reasons for that, but the pattern is reversed in one type of myositis, which is inclusion body myositis. This pattern is totally flipped in inclusion body myositis, where male are much more common than female, and typically in elderly age group. Okay. So just I'm going to skip. I think we've already covered. The other point I always make is myositis affect all ethnic groups. So we know that obviously Caucasians are involved, African Americans gets it, Hispanic gets it, Asian gets it. And it turns out that patients with color actually has more severe, or at least they have more severe outcomes of myositis for various different reasons. And it's complicated to go into the reasons. Partly the reason is delay in diagnosis or access to cares and other issues as well. Obviously, genetics does play a role there as well. Now, next I'm going to take you through a journey from history to all the way to the diagnosis, how a doctor goes from A to Z in diagnosing myositis. So if somebody comes to my clinic, what's going in the back of my mind? The unfortunate part is it's not clear to the patients because, doctor is not obviously verbalizing all these steps in front of the patient. So I just thought it would be a good idea to take you through a journey from all history to all the way to the diagnosis. Okay, so first of all, history is very important in myositis. The history tells us a lot of different things. So when a doctor is taking history of your muscle weakness and skin rashes, they also should take history of other organ manifestations like their lung, shortness of breath, joint pain, Raynaud's, difficulty in swallowing, calcium deposition, because as we discussed, it's not a muscle disease alone, and it's not only skin and muscle either. It is multiple different organs, including heart, could be involved. What doctor does is ask you various questions about pattern of your weakness, and they're trying to differentiate, does the patient have muscle weakness, or could it be patient have fatigue? Because the two are very different things. Or the patient actually have muscle pain, and that's why their activity is limited. Or it could be sensory loss of that particular limb, and that's why they're not able to function properly. So it's important for the doctor to understand, is it muscle weakness, which basically has patient having difficulty even performing the single repetition of that task. For example, getting up from a chair, lifting a gallon of milk. Whereas fatigability or fatigue is inability to continue to perform a task after multiple go. And one point I always make it to the patient, muscle weakness is almost must for the myositis diagnosis. It could come with fatigue, it could come with myalgia, but you need to have muscle weakness. The only exception to that rule is the patient with clinically amyopathic dermatomyositis and the patient with antisynthetase syndrome. Okay. The other point I always make is the doctor is also trying to assess how quickly did you develop these symptoms? And this is very important because we know certain things develop very slowly and progressive. For example, inclusion body myositis develops over the years, whereas some form of myositis develops over a few months, whereas certain other forms develop over a few weeks to days, sometimes even. So they're trying to always figure out what pattern does it fit. It's almost like with the history, they're trying to form a pattern. And then also, is it a chronic problem or you have intermittent weakness? I have many patients who come in with intermittent weakness, means they were perfectly fine playing basketball, they had no weakness, and they now next day they're admitted to the hospital with a CK of 50,000. Okay, and then their CK gets better, they go back to playing again. So the pattern of weakness of chronic versus intermittent is also important. In myositis, we typically see chronic pattern. Then what the doctor does, partly through the history, partly through the exam, they're trying to understand what group of muscles are involved. Is it the muscles that are proximal, which means they're closer to the body, like shoulder or hip muscles, or abdominal muscles or back muscles? Or is it more hand, writing, grip, fine motor skills, or walking or toes that are weak? Okay. With that, they're also trying to form understanding of what type of myositis could it be. The other thing they're trying to understand, is the problem symmetric or asymmetric? That means, is it on both sides or only one side, or one side is more affected than another? Is there any sensory loss and so on? Because the sensory loss would indicate the patient has neurological problem rather than muscle problem. And then they'll ask all sort of questions to understand what other organ could be involved. For example, for lung, my typical question is, have you experienced any shortness of breath while at rest or while walking, which is more than usual or more than your peers or colleagues? Joint pain or swelling, difficulty in swallowing could be a major problem in many patients, and so on. Then we go to family history. We try to understand, do you have family history of muscle disease or autoimmune disease? A family history of autoimmune disease points towards myositis, whereas a family history of muscle disease actually points away from myositis, because myositis is not typically familial in a way. That means the autoimmune disease tend to come in the family. So if somebody has a myositis, the family member may have some other autoimmune disease. So they do tend to have family history which is positive for autoimmunity, but they typically don't have family history which is positive for muscle weakness. And if you see a patient who has a family history of parents or sibling with similar patterns of muscle weakness, that points more toward genetic problems of muscle. Then we take history of alcohol or drugs, because they can also cause myositis or muscle inflammation and muscle weakness. And then we take history of medication. As you may know, many medication, including statin, can actually lead to myositis. Many other drugs here listed that can cause muscle weakness or myositis, and it's important for your doctors to know about these medications who can lead to effect on the muscle. And then come to the physical exam. In the physical exam, the most important part that the doctor do is something called MMT, or manual muscle testing. And I'll show you some images of that here. Basically, in these images, you're seeing the doctor examining your strength of various different muscles. Your arm muscle, your leg muscles, and your wrist muscles, and your neck muscles, and so on. And the doctor is trying to understand the pattern and the level of severity of the muscle weakness, so that they can come up with a conclusion. How severe is the muscle weakness? How active is the muscle disease? What's the pattern? And all of that information will go towards making the diagnosis. Okay. Then they look at your skin. These are all the various rashes of dermatomyositis I'm showing. This is typically called Gottron papule on upper left corner on the back of the hand. The one on the bottom left is called heliotrope rash, which is on the eyelid, and then one in the middle is called malar rash, which is on the face. One on the upper chest is called V sign. One on the upper back is called Shawl sign, and so on. Some doctors may actually also look at the nail folds. They're trying to look at, is there inflammation around the nail fold, because that can also indicate dermatomyositis. Now, once they've done the history and physical, they kind of have a very good impression whether it could be myositis or other muscle or nerve problem. Second, if it is myositis, what type of myositis it could be. They have a pretty generally very good guess by that time. Then what they do is typically they order muscle enzymes, and they order a muscle enzyme called CK. And what I teach is that you should order 5 muscle enzymes, because technically there are 5 different muscle enzymes, including CK, aldolase, LDH, AST, and ALT. And by the level of those muscle enzymes, it can also help them how severe is the disease and what's going on. Typically, we say very low levels of muscle enzyme, or very, very high, sky-high levels of muscle enzyme, like 50,000 or more, may point away from myositis. The other point to note is dermatomyositis is unique, because dermatomyositis, although most of them have elevation of muscle enzyme, but a good about 20-25% patient may have no elevation of muscle enzyme, still pretty bad active disease. The other point I always make is AST and ALT are technically called LFTs, or liver enzyme. And your doctors don't recognize AST and ALT as muscle enzyme. They recognize them as a liver enzyme. And many doctors does the mistake of calling AST and ALT a liver enzyme. And since the liver enzymes are elevated, they do the liver biopsies and liver tests, and turns out nothing is wrong with the liver. The AST and ALT were coming from muscle. They kind of sometimes forgets that AST and ALT also come from liver, because in our training, we are so talking about AST and ALT as a liver enzyme all the time. Like 99.99% of the time, we are trained that AST and ALT are the liver enzyme. And that's why, we kind of forgets that they're also muscle enzyme. Okay. Then what the doctor does is they order a test called ANA, or anti-nuclear antibody. And what's interesting for myositis is ANA is a flip of a coin for myositis. It could be positive. If it's positive, it's helpful because it indicates autoimmunity, and myositis is an autoimmune disease. But if it's negative, it does not rule out myositis. So that's a very important point here, doctors, to know that ANA is great to have, but it's not a good test for myositis, at least. It's a great test for lupus, scleroderma, and other autoimmune disease, but not for myositis. It's a flip of a coin. What we see in the myositis is the same ANA, which is called as negative, also have abnormality in the other part of the cell, which is what we call a cytoplasmic staining, and that's typically positive in myositis. So the typical ANA is negative or positive 50-50. Then what a doctor would do is, typically doctors in past have ordered electromyography or EMG and nerve conduction study. Many of you may have had that test. And that's a very, very specialized test. A very trained person called neurologist does that test. What that test does is differentiate from a muscle problem and a nerve problem. So step one that test does is it a muscle problem, nerve problem, or a muscle-nerve junction problem? Okay. So it's a very helpful test from that standpoint. It rules out the nerve problem from the muscle problem. And so it's a very good test from that standpoint. But the problem is, if it tells you it's a muscle problem, it cannot tell you it's a myositis problem. So it doesn't help to differentiate further. It cannot say it's for sure it's myositis. This test cannot do. But it's also a useful test as a guide for muscle biopsy, because it can tell which muscle is abnormal or what area is abnormal. And the doctors who's doing the biopsy then can go to that specific muscle to get the sample of the muscle to be tested. But nowadays, more and more doctors are ordering muscle MRIs. And the reason is muscle MRIs are easier to order, and it does provide us a very useful information. The fortunate part in kids is the kids can get whole body MRI because they're small, but adults typically will order a thigh MRI or pelvic MRI because there's a lot of muscle there, so we can easily look at the pattern. We use muscle MRI for three reasons. One, it can help us in diagnosis because pattern of muscle involvement are different in polymyositis versus dermatomyositis versus inclusion body myositis. But also, we can do MRIs at baseline and do MRIs in 3 months or 6 months or a year to understand is the treatment working or not. Sometimes patient comes with muscle weakness and we're not able to understand is it the damage or active disease, and that's why an MRI can be helpful. And lastly, but not the least, MRI can be helpful as a target for muscle biopsy. So then once we've done all these tests, the last but the gold standard test, the ultimate test, is a muscle biopsy. We recommend muscle biopsy on almost every patient, but there are some exceptions to that rule. Muscle biopsy can really differentiate between all different types of myositis. That's the best part of the muscle biopsy. It can tell, is it polymyositis, dermatomyositis, is it necrotizing myopathy, is it inclusion body myositis? Because the pattern of muscle abnormality on biopsy is different for all these different diseases. Won't go into detail, but because of that reason, we believe dermatomyositis is not simply polymyositis with rash. The muscle biopsy itself is very different of dermatomyositis and polymyositis. So this notion that if you have a rash, then it's dermato, otherwise it's poly, is not truly correct. So I said most patients should get muscle biopsy. There are some exceptions to the rule. Is it a patient with a classic dermatomyositis, which means patient has a classic rash, classic weakness, classic muscle enzyme elevation, classic antibody, I think you could skip muscle biopsy and perhaps could only need skin biopsy in those patients. And it has to be in the eye of a dermatologist or rheumatologist who knows the classic rash, and they're sure that this classic rash is dermatomyositis rash. Okay. Last but not the least, even after the diagnosis, or sometime during the diagnostic process, your doctor may order something called myositis autoantibodies. And this is a Venn diagram of various autoantibodies. All of these bubbles are an autoantibody. And I don't need you to remember all of this, but the point here I'm trying to make is that these autoantibodies are incredibly helpful. One, each of the autoantibody group represent a unique clinical features. So if you have an antibody, your doctor has an idea what organ could be involved, number one. Number two, they also have a unique prognosis. That means your doctor also have an idea how good or bad your future is going to be, how difficult would it be to manage this disease, or how easy would it be manage this disease, those kind of things. And then last but not the least, doctor could also tailor your treatment based on the autoantibody you have. Not always, but sometimes, yes. For example, rituximab is a treatment that works really well for this big group, this big pink group of autoantibody called anti-synthetase antibody or Jo-1 antibody. The other good part about these antibodies, they are highly specific. That means if you have a myositis-specific antibody, then it's a high likely that you have the disease. But they're not, as a standalone, each antibody is not very sensitive. That's why we recommend ordering the whole panel of myositis autoantibodies, and that does increase the sensitivity overall. So what I'm going to do in next quickly is going to introduce you different types of myositis, okay? So that you just, this is not for you to, this is more for you to understand that how each type could be very different from the other type. So first I'll talk about antisynthetase syndrome. Antisynthetase syndrome is a syndrome which is a subset of myositis that affects lung as the most common organ, followed by muscle, which is myositis, followed by joint, which is arthritis. So it's typically an interplay of three things: lung, joint, and muscle. So patient with interstitial lung disease, myositis, and arthritis. But it also has some unique other clinical features, which such as Raynaud's, patient get fevers, patient get these called mechanic's hand, which basically cracking and thickening of the lateral aspect of their finger. There are autoantibodies that are associated with antisynthetase syndrome. And because of the lung predominance of this subgroup of myositis, a lot of patients die of lung disease in this condition. That's why we pay a lot of attention to make sure we evaluate your lungs in myositis and make sure you don't have a interstitial lung disease or pulmonary fibrosis. Because if you do, then we need to treat it aggressively. Otherwise, it can be a bad outcome. And the good news in this is, if we find the lung disease and if we find it early, it is quite reversible. I have patients whose CT scan almost normalized, as I'm showing you on the figure here. The top figure is before the treatment and the bottom figure is after the treatment. You see how clearly it improves. I have patient who comes on 5-6 liters of oxygen, and with treatment, they actually can get off oxygen. The key is early recognition of the disease, because once the scarring is set in and is deep, it's very difficult to reverse that scarring in the lungs. Now, going to another form of antibodies called disease called necrotizing myopathy, or NM. This is a newer form. In the whole, and this is called a very different name. Some people call it immune-mediated necrotizing myopathy, or IMNM. I call it necrotizing myopathy, or NM. Some people call it necrotizing autoimmune myopathy, or NAM. But essentially, they are all the same. And in the whole world of necrotizing myopathy, it comes in three flavors. One is the patient with anti-SRP antibody. One is the patient with anti-HMGCR antibody, and one which the patient does not have any antibody. So they're typically about 1/3, 1/3, 1/3. And the important point to remember is this anti-HMGCR antibody has a high association with statins. Statins are cholesterol-lowering drugs that are typically taken by our patients, such as Lipitor and other drugs that are called statin. And its rare side effect of statin is that they can lead to myopathy. So clinical features of necrotizing myopathy. Now, it also comes in two flavors. I told you SRP and HMGCR. SRP happens in younger patients typically. HMGCR happens in older patients. But the key is both of these groups develop acute onset of severe weakness with significant muscle pain. They typically have very high CK level, and they're basically, it's a acute and significant muscle death, sort of necrosis of the muscle. And because of that, they have poor prognosis. In fact, most patients in my clinic who have permanent muscle weakness, who comes in a wheelchair or some sort of assisted device, they typically have history of SRP. It's just, it attacks the muscle so quickly and so much that by the time patient gets the medical attention and gets treated, they have already lost a significant amount of muscle which cannot be recovered. So that's why we recommend that this entity should be treated very aggressively and very early on. And how do we know it's necrotic muscle fibers? When we biopsy these patients, what we find is muscle necrosis, pure death of the muscle, and a fast death of the muscle. And that's why to treat this patient is an urgency. Now, going to dermatomyositis, as we remember, dermatomyositis also have many autoantibodies, and each autoantibody comes with a unique clinical feature. So we'll go over some of them. Most importantly, I want to go over an entity called clinically amyopathic dermatomyositis, or CADM. Basically, these patients have significant rashes that are classic for dermatomyositis, and our dermatology colleagues get these patients first because they don't have muscle problem. These patients have skin problem. And they have classic dermatomyositis rashes, but they don't have any muscle weakness. They don't have any complaints of muscle weakness, nor they have any objective strength testing weakness. So these patients, we call them as clinically amyopathic dermatomyositis. And the reason these patients have become very important, even though they are minority of the patients, at least in rheumatology world, they are minority. Maybe in dermatology world, they see a lot more of these patients. But because of this antibody called anti-MDF5 antibody, it's a rare antibody, only seen in about 5 to 10% of dermatomyositis. But it's such a bad antibody that if you have this antibody, then you're going to develop interstitial lung disease or pulmonary fibrosis in 50% of the cases. But what's the bigger problem is that this type of lung disease tends to be very aggressive, very rapidly progressive. So I have lost some patients with this type of lung disease just because it progressed right in front of your eyes very quickly. And by the time you get to do anything, patients already requiring oxygen or hospitalized or requiring ventilator support and so on. The fortunate part is that now we know how to recognize this disease by certain specific rashes. One of them I'm showing you on the screen called palmar papules, where the rash is on the palms rather than on the back. Now, you can have the back rash, but the palm rash is characteristic. And then also with this antibody called anti-MDF5 antibody. I'm going to skip some slides. The reason this is important is I'm just showing you survivals of the anti-MDF5 antibody. If you look at the patient's percent survival, patients with positive antibody have much poor survival as compared to patients who don't have anti-MDF5 antibody. Remember, I was telling you that antibodies can also help in prognostic. And that's how a good example of how antibody can help in prognosis. Look, most of these patients die very quickly within like a year. And that's because they develop rapidly progressive interstitial lung disease. Going to another antibody called TIF1 antibody. This is also a very unique antibody. The same antibody is present in adults and juvenile patients or kids. And they have a very same characteristic. They cause severe skin rashes and calcium deposition and cutaneous ulcerations. So very problematic skin rash. But in adult, this antibody is associated with an underlying cancer, whereas in kids, this is associated with no cancer. So same antibody, same kind of skin disease, but in adults, especially elderly with cancer, juvenile, no cancer. And it is one of the studies suggested that if you have this antibody, the likelihood overall, what we call a sensitivity and specificity of having cancer is about 80%. In our clinic, it's not that high. We believe it's about, depends on the age. If somebody is more than 50 years of age, it's probably 80%. But somebody younger than age of 50 is typically drops down to 20, 30, 40%. So in summary, I hope I've helped you recognize how these myositis autoantibodies are incredibly helpful in putting the patients into the right bucket of myositis generally, and that helps your physician to narrow the focus of your monitoring and your intervention, and sort of more what we call as personalized medicine in a way. Now, coming to treatment, in last few minutes, basically, up until now, there was no FDA-approved therapies. We were using steroid and ACTH, and those were approved in 1950s. Fortunately, we now have at least one therapy, and I'll talk to you about that in a minute. But the way we used to treat patients with myositis is using this algorithm where you have steroids on the top. We used to use a lot of steroids, which actually caused a lot of damage to our patients. Then first-line drugs used to be methotrexate or azathioprine. Second line, we'd use mycophenolate or tacrolimus. As a third line, we used to use rituximab or cyclophosphamide. And then we used to use IVIG as an adjuvant treatment or as a concomitant treatment or a companion treatment whenever we are not seeing the desired results from first, second, or third line treatment. And then the guys on the side is basically trying to represent exercise. And what they're trying to say is exercise is anti-inflammatory for myositis. It's very helpful to recover the lost muscles in myositis. So we should start exercise early and continue till the patient is in remission. Okay, now coming to how we got to an approved therapy in dermatomyositis, at least. Now we have an approved therapy called IVIG. All the approved therapies happen through clinical trials. So I'll encourage our patients here, if you are eligible, then participate in various different clinical trials and studies, because that's the only way to get help for our patients in terms of treatment. So this is a study where we did efficacy and safety of Octagam, which is IVIG, in patients with dermatomyositis. And what we simply did is we randomized patients. Half the patient got IVIG and half the patient got placebo for first 16 weeks. And then everybody got IVIG for next 24 weeks. And what we found was that patients who got IVIG, about 78% patients got minimal improvement in about 16 weeks, which is quite good. Within 16 weeks, they improved to minimal thresholds. And as compared to 43% in the placebo group, that's a difference of 35%. It's a very significant difference. And not only the minimal improvement was there, but when we look at the moderate and major improvement, then also we saw that patients who got IVIG has far superior improvement levels or percentages as the patients who did not get IVIG. But we also recognize some safety and tolerability issue. And that's another reason that we should do clinical trials, because we discover safety and tolerability issues which we may not discover while just giving drugs in our clinic. So first of all, in this trial, there were many adverse events. But the good news is most of the adverse event, the severity level was rather mild. But also, the important point we learned in this trial, the relationship of the side effects was mostly drug-related, which means, or infusion-related, which means the side effects were happening predominantly only during the time of infusion. In other words, when these patients were getting the infusion, they were getting these side effects of fever, nausea, vomiting, and headaches. But after the 2 days or 3 days are gone, they were not having these side effects. So it sort of help us to tell our patient, look, you may get the bad side effect, but it's going to only last for a few days. And a lot of our patients say, oh, then it's fine, and then they are able to move on. But we also discovered another unique thing in this trial, which is blood clot problem, which we had not thought about. That's why, again, this also shows the importance of clinical trial. Before doing this clinical trial, I was giving patients IVIG without any consideration to their overall risk of formation of blood clots. This trial taught us that patients with IVIG have higher risk of forming blood clots, especially myositis patients have higher risk for forming blood clots if you give IVIG fast. So now what I do after knowing from this is I look at the risk of my patients of forming blood clots. And if they're high risk, I would rather not give IVIG. And if they're lower risk, I would give IVIG, but I would lower the risk further by giving slow rate of infusion for IVIG so they don't develop stroke or heart problems or clot in their lung and cause significant issues. Anyway, this trial led to FDA approval, which is the first FDA approval after a long time, and for only FDA approval which is based on a clinical trial. So in summary, we looked into the old and new classification criteria. We reviewed the workup in the diagnosis of myositis. Again, myositis biopsy is important. I explained you the rationale and importance of myositis autoantibodies. IVIG remains the only FDA-approved treatment, although there are many other treatments that we use to improve our patient's life. And we need more clinical trials or studies in this area. It's a significant unmet need. With that, I would like to thank you from Pittsburgh Myositis Group